With your permission, what I thought I'd do, because people generally seem to be a bit ignorant about the WHO and what it is, and they believe it's got lots of money, and why isn't it doing this, and why isn't it doing that? So I thought I would just spend a couple of minutes on talking to you about that, because it is important. First of all, when did it form? Well, after the end of the Second World War, one of the things that the United Nations discussed was setting up a global health organization. And the constitution for WHO came into force on the 7th of April 1948, and it's celebrated every year in Geneva. Well, who is the WHO then? If that's the WHO, WHO is the World Health Assembly, and they are the decision-making body of the WHO, attended by delegations from all WHO member states. This is a United Nations organization, okay? So every country, 194, give or take one or two, attend. And this focuses on a health agenda prepared by the executive board of WHO. It'll become a bit clearer in a minute. So it's the old League of Nations building, which is a beautiful, beautiful building indeed, both inside and out, in the Palais des Nations in Geneva. Now, we've got these two bodies there for what are the functions? The WHA, they determine the policies of WHO. They appoint the Director General, which they will be doing in about 6 months' time. They supervise financial policies, review and approve the proposed programme budget for WHO. And they only meet once a year, in May, in Geneva, and it'll be the week after next. So they're not sitting the whole time, but every single country sends their Minister of Health, and or the deputy, and they make the resolutions pass or not. So getting back to the WHO, the executive board has 34 members at any one time, and they rotate, not in any equal fashion, but I won't go into that. They're there for 3 years at a time. The main board meeting, at which the agenda for the May WHA meeting is agreed and resolutions for forwarding to the May meeting are adopted, usually in January of each year, but there can be one or two at a later date. So the main functions of the board are to give effect to the decisions and policies of WHO. So they will put forward resolutions up to WHO to consider and pass or not. And if they do pass, then they will issue instructions back down to WHO to advise and generally to facilitate their work. Now, the Secretariat is staffed by a small number of people on fixed-term appointments, working at headquarters, in the 6 regional offices, and in countries. And it's worth pointing out that the regional offices and the country representatives are not workers in the true sense of the word, they're diplomats. And the country representative will not come from the country they are representing, if you like. So in Zambia, the country rep will not be a Zambian. I won't go into what they actually do. Now, the important thing is all about money, as I've alluded to. And the WHO gets their money from 2 sources. Each member pays their annual dues. And there are voluntary contributions from member states and NGOs, etc., such as foundations, investment banks, etc. Now, the assessed contributions are essentially wholly flexible because they can be agreed in advance. The WHO can decide what they're going to be for this year or next year. They can up them or down them. And therefore, they are predictable. So WHO will know now what fees will be coming in, not what fees, what dues will be coming in next year. Now, voluntary contributions, by definition, are voluntary, and thus don't have predictability. And you can't guess where they're going to come from or for how long those contributions will be. Now, the nub of all this goes back about 20-25 years. And we use this word tied. The assessed contributions, those are the dues from each country, are not tied. In other words, WHO can do what they like with that money. But most of it goes to pay those 8,000 workers. Now, voluntary contributions, which comprise 80% of money that WHO gets, are tied. What do I mean by that? 20 years ago, the big organisations, the big investment banks, the big guys like Gates and all that lot would give money to WHO in a generic term to fight this or to increase that. And WHO could do what they like with that money, in a sense, as long as it was within those generic confines. But then it all changed with HIV/AIDS. Now the money was sent to WHO to combat HIV and AIDS. And millions and millions and millions of dollars were sent to WHO. But WHO couldn't do what they wanted with that money because it was tied specifically to that objective and others too, tuberculosis, malaria, and what have you. So that essentially means that the only money that WHO itself can spend, or what it wants to spend, comes out of that assessed contribution, the non-tied ones, of which is very little, because most of it, as I've said, goes on paying those 8,000 guys. So I want to make it quite clear, because people are under the misapprehension that WHO is swanning around in lots and lots of money, but they are not. So now we come to the nitty-gritty, really. This Health Assembly resolution, which was passed unanimously almost exactly a year ago. This was first mooted 38 years ago, and it's taken us that long to actually reach our goal. Because you have to remember that the WHO is a public health organisation run by public health doctors. And it wasn't until relatively recently that they decided that surgery was in fact a public health issue. And so strengthening emergency and essential surgical care and anaesthesia, that should possibly be all one word really, surgery and anaesthesia these days, because you can't have one without the other, as a component of universal health coverage. Now, in actual fact, that statement doesn't really say very much, because you can interpret it in all sorts of ways. I mean, what actually is universal health coverage? Is it having lots and lots more hospitals where bad surgery is being performed and more people die of bad surgery? Or is it having lots and lots and lots more surgical providers trying to do their best in only a limited number of hospitals? So it's how you interpret these things that is important. I'm not going into that anymore now. Each country, and remember each country voted for that resolution, will have a mission statement and a vision and a goal. And it's relatively easy to write those down. What isn't quite so easy is to translate policy into implementation. Now, there are lots of ways of doing this. Advocacy is very important. Advocating for the neglected surgical patient. Who do we advocate to? Well, essentially three groups. The general public, the people who are going to put up the finance, implement this resolution, and thirdly, and most importantly, politicians in the countries, because it's the countries that are going to have to implement this, not you or I or anybody else. And within that, of course, it's mainly the governments, with support and advocacy from the guys on the ground who are undertaking anaesthesia and providing the surgical service. Yes, they are important too, but it's the politicians. They are the ones with power, governments. And they are the ones who are going to have to advocate for more finances, or not, maybe not more finances, but making sure that more of the bucket that's been put aside for health goes on surgery. And this is the rub, do you see, because the Ministry of Finance, they're the real important guys. And if the Minister of Health goes along and bangs on the door and says we want more money because of blah, 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 he'll say, well, that's fine, we're giving you plenty of money last year, no problem. He said, you can divide up that budget yourself. And so you're into robbing Peter to pay Paul. And we think, because we're in surgery, that surgery is the most important thing. And I can tell you it probably isn't. And some years ago, I was asked to go and see, not because I was ill, but the only psychiatrist in Zambia. One medically qualified psychiatrist in a country of 17, 18 million people, something of that nature. One. And mental health is an enormous problem in Africa. Probably more of a problem than surgery. So it's all very well for us to say, come on, you give us plenty of money. But the guys, the poor Minister of Health, he's got all these problems to sort out, one of which is surgery. So it's not going to be easy. It's not going to be easy for them to get their governments to put more money into surgery or surgical and anaesthesia care. And you need resources. I mentioned hospitals. But it's not just hospitals and doctors and surgeons. It's the Judys of this world, theatre nurses, it's the porters, it's the laboratory staff, it's the technicians, it's the people to mend equipment when it breaks down. It's a whole gamut of resources that you need. Infrastructure, of course, is important. We, in order to practice surgery, need to have somewhere to do it. Now, somebody was mentioning they read the Lancet Commission. I was tangentially involved in that, but I'm not the great one for targets, and in particular targets that contain percentages. And they have said, for instance, that by 2030, 80% of the world's population shall be within 2 hours access of a facility that can undertake a laparotomy, an emergency cesarean section, and to manage an open fracture. Well, I'm sure you guys there know that 2 hours in the dry season is not 2 hours in the wet season. It could be 22 hours or 2 days and 22 hours if some lorry has completely mashed up the road or slid down and crushed it completely and what have you. So if you're going to have a target, it has to be realistic. It has to be realistic. You need hospitals, you need roads, water, electricity. It's not just building a hospital. And it's not until you think about all this, you think, hey guys, this is not going to be an easy thing to achieve by 2030 or 2020 or whenever. Workforce. One of the big problems with workforce is not just numbers, is incentives. In many countries, especially out in the rural areas, you'll have clinical officers, you'll have all sorts of other people who are paid a wage. And they are paid for, as I say, working so many hours a day. And that's what they will do. And if the patients turn up when their working day is over, tough. There's no incentive for them to actually do more work. And incentive is a big problem. They may be committed, but just committed for that short space of time per day. So the workforce we've got to increase. We can't increase surgery without increasing the workforce. And that's essentially going to mean education and training, which is partly what I shall mention in a second. But it's not just running courses and this, that, and the other, because the education, the training has to be standardised, has to match a certain quality. And then you've got all the problems about credentialing. And the care delivery is, of course, vital. Access to integrated systems of care, not odd good spots here and there. Essential medicines. Some of you were at the talk on Wednesday afternoon. You heard Walt Johnson from WHO talking about ketamine. Ketamine is a drug which you guys from Africa will know very well. It's absolutely vital, not only as a form of anaesthetic, but also for pain relief. But you need other medicines. You need other analgesics. You need antibiotics. And all these things have to come together. You can't just cherry pick this bit and that bit to provide universal health coverage. It just doesn't work that way. Information management is probably the first thing countries have got to do. The collection of data is, on the whole, if I say non-existent, I'm not exaggerating too much. If data is collected, it's often by hand, handwritten data. One of the first things to implement this resolution they've got to do is to get an adequate data collection system up and running. And it's not just a question of collecting data. You've got to validate that data. You've got to analyse that data. You've got to put that through a research method to find out the evidence for change and what changes you're going to bring. And these things are going to take time. They're going to take technical support as well. I'll come back to why that's important for us in a second. Research is not done very much in Africa. It is done. Professor Mewburn, who is here in the audience, knows this more than I do. But overall, certainly in East Africa, it is not undertaken very much at all. And we just desperately need research to look into various aspects of how we're going to expand surgical care. Partnerships. Again, this is something where we could come in. At the moment, as you've heard Sister Judy say, that Tropical Health Education Trust manages money from DFID, and we in ASGBI here have had 3 grants, totaling upwards of about £700,000. We need that sort of money to make a difference. You can't just do it on a shoestring. I've talked about education and training. What do we mean by that? How are we going to approach that? It depends very much on what the countries want. It's not just a question of us going into a country and saying, right, we're bringing this course in and that course in. It's the countries that have to implement. Our role is to advise, support, recommend. If you need some money to get some system going, then we might be able to help with that. But if they see that education and training is the most important aspect, or one of the most important aspects, then that is where we could give advice and help. But it has to be a two-way thing, and we're not in charge. They are in charge. Each government is in charge. The G4 Alliance Judy has mentioned is also useful in this, hopefully. What we need to do desperately is a scoping exercise to find out what each country would like and would want. A year has gone by since this resolution was passed, and virtually nothing has been done since. I say virtually, some things have been done. The Lancet Commission was referred to. They have started doing various things. But on the whole, not many countries have got very far down this line. So just to mention a little bit about the Association of Surgeons, what we've done about 103 courses in 16 countries, mainly in the Kozetsa region down here. I appreciate that. Botswana's not in Kozetsa, but don't worry about that. And West Africa. And of these 103, 38 were basic surgical skills courses, which we started some long time ago. And we don't do those now because the most important thing that we do is at the bottom, actually, is training trainers. So we don't go back and do the same thing over and over and over again. We train trainers to do it. Colorectal skills courses, laparoscopic skills courses. I have to say, when we started out, against undertaking laparoscopic skills courses, because I couldn't quite see the point in teaching guys to do laparoscopy if they couldn't maintain their skills, because they may well not have any of the facilities. And people did agree with me. And then, if you walk around Africa a lot, you'll find people sitting in beds in hospitals all over the place, having had laparotomies. Laparotomies because they don't know what's wrong with the patient. Now, in this country, we do an MRI scan or a CT scan or what have you. But out there, they don't have those facilities, so they just have a laparotomy, not a small incision, often a very big incision. And then they are inoperable, and they'll sit in bed for maybe 1 week, 2 weeks before they're taken away. So in fact, what I think would be sensible would be to look at the possibility of teaching guys diagnostic laparoscopy. Not a big incision, not 2 weeks in hospital. A diagnosis could be made, so people, they could do a laparoscopy and maybe a biopsy, but no more. And I think that is something which is realistic. You don't need, I'm told, as much kit or as much training. It doesn't cost very much to keep a patient in hospital, in a district hospital, in rural areas. It does cost something to get the equipment. But that might be something to pursue slowly over the years. Anaesthesia workshops, we're in the middle of doing this. We've done 3 out of 6. The MSE courses, we did 7, and they've been handed over to Kozetsa now. And with all these courses, as Sister Judy has said, we run theatre and recovery nurse training courses. And above all, the training the trainers. So how many people have we trained? Well, quite a lot of basic surgical skills. 26 colorectal skills, 126 MSE. So far, 36, it'll be double that number when we've finished. And you'll see train the trainers, 410. You see, that's the most important thing. In fact, we go out and we do a train the trainers course, and as part of that, we get them to train some trainees. And 647 and a half theatre nurses have been trained. So that, I hope, gives you a little bit of insight into what the WHO is and the WHA, what this resolution is, who's got to implement it, where our role could be in assisting and recommending and helping, and just to tell you a little bit about what we have so far achieved. So, thank you very much.
Now for something completely different. My name is James. I'm a senior lecturer in clinical colorectal surgeon at Imperial College. I'm not a global surgeon, and I don't have the wealth of experience that many of you people have of really working at the coalface in the developing world. But in fact, actually, my first true love is computational biology and systems medicine. But I've been working in digital health and in remote learning for some time, and it's a great pleasure to talk to you today. Now, you've had multiple talks in this conference over the last few days on social networking, crowdsourcing, big data analysis, and the importance of digital health going forward. And really my objective today is not to be specific, but to give you a global overview, literally, of where I see technologies in digital health having impact in the developing world and where I think we need to be looking. So, just some disclosures. I'm a director of a company that makes mobile computer games, but this has got nothing to do with this, so I don't think it's that relevant. So, this, just to be a little bit interactive, has everybody voted in this poll? Okay, so this is a poll run by the Royal College of Surgeons. It's been having some traction on Twitter. Surgery in the digital age, is it evolution or revolution? And the debate basically has been centered on this, and everyone thinks it's evolution. I'm going to argue against that, okay? Again, argue against the house. I think it's revolution, particularly in the developing world. So I started here. This is me. I'm sat on the front row, just there. And this is in a platform called Second Life. Second Life was a game that was kind of big in the mid-noughties, and it was something called a massive online role-play game. Okay, and you went in there and you went into a virtual world as an avatar, and each digital person is a representation of the digital self. And we ran conferences on surgery in this, and we had global audiences that used to come in, and we have a real-world speaker, and then all these little avatars could interact, and it was fun, and we published. I think we're the only BMJ publication on it, so I'm quite proud of that. Second Life had some problems, and this was the problem, okay, that had people like that in it, okay, and that's probably someone called Colin from Dagenham, who's a 50-year-old, man who lives alone. And there was no educational, it was hard to argue the educational value of it, and we ended up working across different platforms. And I'm going to come back to Second Life and the work that we do in it now in the developing world, and how we've managed to find serious applications for these sort of online technologies. So when you listen to TED Talks or when you go to conferences and people talk about technology, there's a few cliches that come rolling out, okay? And these are those cliches. Everybody likes to quote Moore's Law and how this is going to dramatically change the way that we use computing to impact on healthcare. This is true. This is true. The second law is that you can't give a technology talk without referring to the Gartner hype cycle, okay? And just so that we can form, here it is. This gets published by Gartner every year or so, and it tells you about the technologies that are emerging, how they're going to impact our life as they pass through an innovation trigger all the way through to the plateau of productivity. Things that are really important at the moment seem to be getting a lot of traction are virtual personal assistants, and at the moment I think augmented reality has probably progressed a little bit along the way. But what does this mean for the developing world, and how are we really going to use this practically? The third law is that people like to make up stupid words to explain their technology and to market it. And there's a lot of silly words, but we're going to kind of focus on these ones, okay? Because I think these are the ones that are going to have the greatest impact in the developing world. So there is a consistent truth, though, throughout all of this, which is that largely we're producing more data than we know what to do with. And this is true all over the world, in the developing world and in the real world. And basically, at the moment, we're just trying to find ways to analyze it. But the real challenge in the developing world is using that data to solve meaningful problems. Bob, much more eloquently than I, has described this, and there's a whole session on this. But the summary statistic is that there are 5 billion people in the world that don't have access to high-quality, safe surgical care. This is a big problem, and we need radical new changes and new technologies to try and solve these problems. And where I come from, at Imperial College, we have the Institute of Global Health Care, and they're interested in trying to find technology solutions to try and solve some of these problems, and also improving the way that these technology innovations diffuse through into the front line of clinical care. And that's a challenge. It's a real challenge in the developing world. And what you end up with any new technology that diffuses through is a period where everyone is quite negative about it, and it seems to have more of a negative impact than a positive one. And slowly over time, it starts to gain traction. And what we find as you go from innovation through to transformation, that there are a bunch of frontline behaviors and a bunch of enablers that allow you to transform that. And the key in the developing world is to identify these, specific for the individual nation or country or problem you're trying to solve, rather than simply trying to apply a developed world strategy to it. So technology is just a caveat, right? Technology is not going to solve everything, okay? And the major issue is that most of the countries that are involved in global surgery don't even have a technology policy. So if you're trying to develop something nationally, there's no government framework to help you do it, which is a problem. But quite a lot of digital technologies are disruptive and seem to bypass that. But if you really want to have meaningful traction, you need policy. And this is actually a slide that came from the World Oncology Surgery Group. And it just caught my eye, because basically what it describes is a network. It's how a patient mobilizes through a system to get to a higher level care, to have some definitive surgical intervention. And this is the same no matter where you are in the world. And there are a couple of key problems. One is communication, and the second one is education. And these really come round again and again. So what I'm going to focus on is how can we use technology to try and solve these problems. So digital health is a kind of rather generic term, and I'm going to try and define it for you as we go through the talk. So digital health in the UK basically means online and mobile platforms and technologies or ways that we analyse data that comes out of these platforms to make health decisions. And in the developed world, we're pretty much all connected, and quite a lot of us spend about over 2 hours a day online, and there's a lot of health apps out there. We can argue how effective or important or useful these health apps really are. There is a lot of debate about it, but whether you think they're useful or not, they're coming, and there's lots of them, all right? And 500 million people around the world will have a health app this year. And we need to look at how we can mine that for the developed world. But is this really translatable to what's going on in the developed world? Well, no. And this is one of the reasons, okay? So if you look at web users, all right, at the moment, 7 billion people in the world. We said 5 billion people don't have access to surgical care. Well, just over 4 billion can't get online. Okay, and that means they're missing out on significant educational opportunities. This report came out this year from the World Bank. I don't know if any of you read it, but it's a good read. It's a long read, but it's a good read. And I'm going to shamelessly steal some of their slides. If we dig down into this population, so these are our global population. About 1.1 billion of us have access to high-speed internet. As I said, about 3 billion people have access to online, to the internet. But the majority of those that don't do have access to mobile phones. And when you look across that sector, these are just the mobile phone operators. The majority of them are India, some of them are in China. China isn't a real country. And then you've got Pakistan, Bangladesh, and it sort of drifts through into some of these other bigger countries, but most of them are outside the top 20. And there is real inequality in the way that that digital data is accessed. So this is looking at populations of users within Africa. There is a very significant gender inequality. Women don't get the same access to online educational tools that men do. But obviously, if you live in a rural community, if you're old, if you are poor, you can't get online. And it's the same actually in Europe. So this is the European data. If you are in a household that is deprived, you're much less likely to get on, well, you're 45 times less likely to get online and use government health services. So this is in fact a global problem. And this just graphically illustrates that. Everything in red is slow broadband, everything in grey is no broadband, okay. So we know that we've got to collect data to instigate policy changes, but you can't do it if you're not online. Why is it important? So these are undersea pipelines carrying internet connections between countries. And what you'll notice is there aren't that many around Africa. There's lots going between Europe and the US, there's lots over here in Asia, but not very many here. Why is that important? Why does it matter? Well, it matters because you can directly link your connectivity to your ability to generate money and your ability to be self-sustaining. So countries like the Netherlands, Singapore, in fact, has the most connected economy. And you can see each node here is relevant to their GDP. And in the developing world, China makes quite a lot of money. It's increasingly becoming connected. It's highly connected. But down in the country here, we've got problems. And most of the African countries we're talking about are down here. They're not connected. They're off-grid, and they can't capitalize. So technologies that are going to make a difference aren't necessarily apps. It's simply connecting people. So Brick is a startup that came out of Kenya, and it's a robust way of getting people online. It creates a local network, a local cellular network, so you don't need to connect to a main pipeline, and people can simply get online to share information. And these are the things that are going to have real impact and are going to allow us to be transformational. You or I share data the whole time online, and this is where the world's data is kept, right? Each little node here, yeah? Nothing in Africa, not a single data warehouse in Africa. And that's because it's largely stored by big companies that are based in the US. And what's interesting is that there are a large number of startups. So Kili is a cloud computing startup, again, based out of Africa, trying to create cloud computing tools for the developing world. And what they do is they don't just create tools, they create open software which developers can use to create functions for their own populations. And this, I think, is where we're going to see significant innovation. So once you've got online, what are you doing? Well, you're mostly sharing cat videos on YouTube. That's true. And in fact, YouTube is the #1 digital media module, if you like, to share information. But we're doing slightly more than that. So this is a map. This is a visual of Twitter usage globally as the world wakes up. And what you can see is that there's a very high spike over the US and over Europe, but Africa pretty much remains pretty dark. There's a few spots in South Africa, but it pretty much is not active. So if you look at, social networks are important. I know that we predominantly use them to keep in touch with friends, but again, you've got to be connected and they're critical. So this basically shows you that Facebook completely dominates both the developing and developed world. All right. So if you want to interact and communicate with people about health, you have to be on Facebook. Twitter only has, so these are the #1 social networks. Twitter only really has traction in Japan as the #1 social network. So if you're trying to communicate with the developing world on Twitter, you're not really reaching them. So China obviously doesn't like Facebook. It has its own platform. If you look at the #2, the #2 is Instagram. Okay, so millennials particularly like to use Instagram. We use a little bit more Twitter usage, and I'll show you some data about that in a second. They like Facebook still in India as #2. So a major problem that we have is that the digital context in the West moves so quickly that actually trying to translate that into the developing world in a meaningful, useful way is really hard. So we are already moving out in social media terms out of the information age. The information age was that I went onto Facebook and I uploaded all of my personal information onto that social network. That made Facebook very wealthy because they knew all about me and they could program things. And as a global population, we stopped doing it, right? And that's made this man really unhappy because he can't predict things anymore. And what we've realized is that for our own data protection, we don't like to do it. But there's been a change, and we don't really understand why that is at the moment. And we've moved into an experience age. Everyone in here is, I'm pretty confident, over the age of 19, right? So you don't know what Snapchat is. But if you're a teenager, you don't go onto Facebook and share information. You take a picture of yourself immediately. And what you do is you send that out there and you look for attention, all right? And this is what we do. And we talk through different cascades of attention. So what happens is, you go to a wedding, you take a picture, that goes out over a telephone network via a smartphone. It's usually associated with some other sort of, GPS or some other kind of information to tell you where you were, and you send it out via an app through some sort of social media network. That's how we work now. And it's moving so quickly that really Facebook has moved away from that, and it's realized that it's got to get into the experience game. So Magic Leap is a startup company. It's an augmented reality startup company, already valued at $4 billion. Hasn't made a thing yet. And it's trying to change the way that we think about how we're going to interact with augmented reality in the future. This is going to have impact, but we don't know how yet. We don't know why. So how, when we don't understand it ourselves, how are we going to make it useful for the developing world? Well, let's just look at the developing world. So when you look at developing world, something interesting, well, in fact, actually, this is global sales. This is global sales of computers, of desktop PCs. They're falling, right? Everything is about mobile phones. This is mobile phone growth. This is app growth. This is smart tablets. And we knew that kids needed computers, and this was one laptop per every trial program that started in about 2005. We've got Raspberry Pi in the UK. We're trying to create hardware to get it out there. But actually, these are not translating out into the developing world. Probably about 5 to 6% of Raspberry Pi products actually hit the developing world. What's interesting is you then compare that to the growth of things like improved water, improved electricity, secondary schools, and improved sanitation. These things, mobile phone use is rapidly overtaking them. So how do we harness that power to change things? Well, first of all, you've got to know what handset you're looking at. So everything in grey is the developed world, and we basically use iPhones. In Africa, you don't. You either use basically a Nokia old handset, or you use a Samsung headset. And it's still important, because if you go back to 1995 and you looked at a chip in a computer, right, an iPhone 6 has 625 times more transistors than a chip from 1995. And basically what that means is, so in fact, actually it's interesting, when iPhone 6 launched, they sold nearly 25 times more CPU transistors than they were on the entire planet in 1995 in 1 week, right? Everyone has got a pocket supercomputer now. Everyone does. And people in Africa too. Okay, so this is extraordinary. This is a revolution, and you can use that in amazing ways, sometimes slightly peculiar ways. So this is a smartphone app that allows you to do your own cervical smear, believe it or not, and then it allows you to upload that image to a crowdsource of gynecologists and histopathologists that will examine that image for you and give you feedback. I'm not sure that this is potentially the killer app, but I was looking for something different than a SATS probe, and that's the only one that I could find. But it kind of illustrates the potential of it nicely. But actually, we can use mobile phones in much more meaningful ways. So this was a report that came out looking at how we might use them to assess migration, preparedness, response and recovery, resource management and accountability, search and rescue. And increasingly, we're finding case reports of these technologies being used in that way to record the data, to record the sort of data that Bob was talking about. You know, mobile phones is the way we're going to do it. But there's problems with mobile phones. They're not that smart. So the more robust mobile phones that we typically see, the Nokia old 3210s, the old kind of bricks that we used to have, they're not quite so smart. They don't have a lot of features. You can't store a lot of stuff on it, and there's not a lot of content to put on them. And there's a problem with getting content on. So we're seeing growth in companies that are now trying to create functions for these old, slightly more redundant telephones that they can actually be used in meaningful ways. And this is a good example. So this little company here recently got another £1 million worth of funding. And what they're doing is they're trying to create mobile ecosystems for workers working in the developed world to help record data on a whole ecosystem of problems, whether it's disease surveillance, childhood immunizations, antenatal care, drug stock monitoring. These products are being developed in the developing world. They're not being developed in the West. So they're being developed by the end users for the end users. This is a program that got a lot of attention. This was a competition run by the Norwegian government looking for developing apps for children. And you know, there's 2.8 million displaced Syrian children out there who get no education. Can we use technology, lo-fi technology, or frugal innovation, as we like to talk about at Imperial, to try and change the way we teach these children? And we're creating content. So Medical Aid Films now makes films to teach people about managing complex surgical problems. There's a very, very good film on there about fistula management, complex fistula management. These are films made and targeted for people in the developing world. Utopia is a company which is trying to create Facebook for your old telephone. Okay, so if you use Facebook, you pretty much use it on a mobile phone. Half of all of the 1.6 billion people that use Facebook do so through their mobile. And this Indian company knows that. And they are now trying to create Facebook in different ways through which which people in the developing world can catch up and use it effectively. They've had about £16 million in startup funding to develop it. It's an Indian company. And I think that nicely illustrates it. Why is that important? Well, look, people are using their mobile phones for different things. 2 billion people live outside of traditional financial systems. And this map shows you people in Africa where mobile money accounts outnumber bank accounts. They don't go to the bank like you and I go to the bank, but they will bank on their mobile. And I think that's going to have a very significant impact in the way that we're going to be able to fund and pay for these healthcares. But critically, if you're using a mobile phone, you can start to measure what's happening. And when you can start to measure what's happening, you get new insights into the way health needs of population change. So Health Map was a company that basically decided to start measuring health data through various social media and mobile functions. And in fact, it was able to predict the Ebola outbreak before anyone else did, because it was doing that. It was capturing data that way. There has been a revolution in the way that we educate. Foam, I would encourage you to look at. It's free, open access, education. Apologies for that word. And it's a concept. There are now 226 blogs, media channels and websites that have free content for medical education. We have Twitter journal clubs with a global impact, and these are now commonly deployed. There was certainly a Twitter journal club that I was involved with for a long time, and it's a very effective way of communicating, and you can reach people that you simply just can't reach. But you will note, again, the majority of it seems to be US-based. And we have a strategic attempt to try and improve education through the mobile platform through people like USAID. So they're putting quite a lot of money into this. And of course, we also have universities. So universities are making their content freely available for the developed world. Wouldn't it just be great to have a surgical university for surgeons working out in the developed world who can come in and have access to all the content we create at our very privileged institutions? And I think maybe that's something we need to look at. I'll finish on this, so I've been talking quite a long time. So serious games. So I told you I started in Second Life. Okay, so we're still, well, we're not in Second Life. So we started doing disaster response validation studies. So we were able to build St Mary's Hospital in Paddington, basically, and stack it full of virtual patients. And then we were able to study patient flow through those patients, but also to try and see if we could teach people how to manage patients during major incidents or disasters. And what's interesting is when you create these virtual systems, you can manage the patient all the way from their arrival in the emergency room to them being appropriately managed at a high level of care. And what we found is that, yeah, you can do that effectively, and you can see that juniors do it not so well and experts do it very well, which gives it a little bit of validity. What we then tried to do is scale it up. So this is two guys looking after some major, some horribly injured virtual patients. We did this around London 2012 when the Olympics was on, because everyone was worried about terrorist threats, and we thought, well, maybe we can help people learn how to manage them. But this was really a triage exercise. And as part of this, we developed a trauma trainer. So this patient has real physiology. They've had a traumatic injury, and all of these patient monitors work. And you can intervene, you can do something to the patient. Each one of these avatars is a real person speaking to each other, and you can run these trauma moulages in real time, and you run it all through an iPad. Okay, so that's how we did it. So we ran trauma teams, and we tried to teach trauma teams how to manage major trauma. What we found was that people like learning this way. That's basically what that shows. I'm not going to labour the detail. But what we thought was, well, couldn't we just use this on a more global scale? And so we tried to do this over 3G networks. And we had a centre, which you can see here in Malawi, and we had a centre down in Cape Town, and then we also worked with McGill University. And we ran real-time trauma training, team training modules in a virtual world. We moved out of Second Life and we developed in Unity, which is a games engine. And we found we could do this very effectively over 3G networks. So this is someone in Malawi, this is someone in London, and they're in the same virtual space with these trauma cases worked up in some detail. These are x-rays. What you can see, interestingly, this is the student, he's looking at the x-ray. This is the same lady. You can see she's looking at the patient over her shoulder, and she's got a completely different view on the computer because she's looking this way, and that's where the patient is. So these people can work in teams of surgeons or experts based in London, and they can study detailed, complex trauma problems. So the summary of all this is that digital health is mobile. Okay, that's the future. If we want to be improving the way that we educate and we communicate in the developing world to improve health and to deliver these global surgery targets, then really we have to be using mobile health. There are good examples of mobile health and digital health being delivered. This is in Montenegro, and you've got to start where the money is. You then push for some sort of efficiency, use those savings as an incentive, and then after that, integration becomes much easier. And it's a model, and it's in the World Report. So I'm just going to finish the last slide, and I'll finish. I know I've been overtalked a little bit, so sorry. I just thought it'd be fun to look at the ASGBI data. So there's a hashtag that's been talking, and so far, when I checked it about 6 o'clock this morning, I was getting on the aeroplane, 500 posts, 184 users. We've reached 326,000 people with 977,000 impressions. That's just ASGBI meeting. And it was interesting. So this was the top dude, Ewan Harrison. Social media, a crucial element of modern surgery, says, this is Professor Sheen, he gave a talk, I think yesterday. And then this was the vote, okay? And this was our spike. So our major spike, we had, I think, 60 retweets. So not a lot, really. Where are they going? They're going on Twitter. I showed you a map saying people in the developing world are not using Twitter. We're talking to ourselves about what we're doing here. We're not really reaching the people that really need it. And what we're doing is we're probably reinforcing engaged people with what we already know. This is where those tweets went. Okay, so they predominantly went to the USA and North America. Some went to Australia. We hit a few hits in India. And I think that's Botswana, maybe. I don't know Africa that well. You guys will tell me better. So there's someone in Botswana listening to us, which is great. And we have a reasonable sex distribution. And these are the most influential people that you have in asset. So my challenge to you is, how are we going to use this technology this time next year? How, as an ASGBI collaborative, should we be using social media to integrate and to communicate with our colleagues working in the developing world right now? Maybe next year we can have a conference with them linking live in, and we can find new ways to speak to them. That's a challenge. So is this evolution or revolution? It's absolutely revolution. This is a stunning growth in the way we use technology in the developing world. It might be evolution where we are in Belfast or in London, but it's an revolution. So thank you. I'll obviously take any questions if you need them.